Uh, I am Professor Mark McGurk, and I head up the Head and Neck Academic Center at University College Hospital. And my subject is head and neck lesions and tumors. I was one of the founding members of HNCF, and you know that we are trying to minimize treatment of head and neck pathology, basically because it's so obvious. It interferes with function and form, and it's unlike other sites in the body where you can close things up in the tummy. You never know anything's been done. But that's not the same in the head and neck. So that's our objective, to minimize treatment for you, the public. So what I'd like to talk to you about today is odontogenic tumors. And you'll immediately ask, what are odontogenic tumors? Well, these are a rare set of neoplasms, growths, which occur in the jaws. Odontogenic means teeth. And they're of a peculiar type. And there are two groups. One is actual tumors, and these are not nasty ones that spread around the body. They just slowly grow in the jaw, and they're silent, and so they're discovered quite large by deformity of the face or on an X-ray. So that's one group. The other one is dysregulation of bone, which again is silent and is found by on X-ray with great big patches of bone missing and lumps within the bone. And that's because the cells there are not working well. So these two groups form the odontogenic tumors. And the big problem with them is they've fallen under the radar. They are so uncommon that very few people see them. And consequently, they don't really know how to treat them, and they fall back on very old-fashioned treatments. And what I'm trying to tell you is there's a revolution in the management of these conditions going on now. And a lot of these conditions can be treated by very minimal surgery. That is the message. You do not have to have major surgery anymore. So I suspect you'd want to know, what are the traditional treatments of these odontogenic tumors? Well, as I've said, they haven't really kept pace with time, and so they're based on really surgery. And the odontogenic tumors came with a reputation of coming back, and that the pathologists advised that they should be removed with about 1 centimeter of clear tissue. And effectively that meant actually removing the portion of the jaw. Now, most of these are in the mandible, about 15% in the upper jaw, the maxilla. So that really meant removing a section of the jaw. And with that, one had to reconstruct that defect. And that meant taking bone, normally from the hip, sometimes from the leg, bringing it up and putting it in and replating it and connecting all the blood vessels up. Long operation, 10 hours or more. And of course, you can imagine the side effects of this type of operation on your leg. You have a big scar on your leg, you're limping, your hip can be sore. And of course, these recover over time, but you're left with all these disabilities, long time in hospital, 12, 15 days. And so it's a big, from our point of view, morbidity. It's just the type of thing that we'd like to reduce if we can. There's a revolution coming on in this subject. Basically, what has happened is that some units around the world have managed to get more and more experience on this, because the experience is so thin on the ground, no one can actually challenge the old techniques. But in Japan, they've been treating these tumors much more conservatively by scraping them out. And in Malaysia as well, and these are countries that get quite a lot of these tumors. The most common is one called an ameloblastoma. And there is a team in Paris, Professor Rouen and me in London, and we held a conference a few years ago here in London examining this whole topic. And essentially, the tumors of the jaws, particularly ameloblastomas and myxomas, can be scraped out. The bone can be then smoothed off with a drill, and using a chemical to catch any of these small cells, one can turn these big ops into a 1 or 2 hour operation with 1 day in hospital, perhaps 2 days in hospital, no repairs on the legs or hip. It's turning into a much smaller op with very reliable results. Now, you do have a slightly higher recurrence rate. It's under 10%, and but it's always back in the bone. It doesn't spread anywhere. It's not you don't lose it or do anything like that. It's always back, and you can just repeat the process. And if you have to, you can go back to the old-fashioned op. It doesn't restrict you. So you've still got all your options. And the other big breakthrough is the dysregulation ones. These ones are due to the cells making the bone not working properly. And there's a whole set of drugs just come on. These drugs are used to stabilize the bone for people who have osteoporosis and things like that. And they work on these giant cell lesions of the jaw. And whereas before, again, we used to cut them out, all you need is some tablets for about 6 months and it stabilizes it. So this whole topic is changing away from major surgery into much, much, much less invasive treatments. What is a bit difficult at this present time, because we're in this period of change and a little bit iniquitous from your point of view, you could go to one hospital with your condition and be offered quite minor treatment and even tablets. And if you went to the next hospital, you could be offered major surgery. And we're trying to stop this or equalize this situation, as it really is not a very good scenario. All surgeons are conservative and they're reluctant to move off their surgical base. And so one of the positive messages that we are trying to give you here on HNCF is that we're informing you. We're making you more aware of what is available so you can just ask some questions. There will be cases where you need major surgery, but it's not very many. That's our message to you. The other thing we're trying to do to convince people is we've just started a national audit. So we're going to collect information on these odontogenic tumors from all around the United Kingdom and ideally Ireland. They are very uncommon. The ameloblastoma is 1 per million people, so that's 60 cases a year in England, and that's the most common one, and there's 15 others. So we're going to collect the incidence of them, we're going to collect the distribution, and also ideally what treatments are being provided, because it does vary. I mean, I know already in London this week or last week, someone had a big operation for ameloblastoma, and there's some surgeons actually advertising themselves by promoting these big operations. And what we're trying to do is make you more aware and more informed so you can ask the right questions. So that's our contribution, the audit, which we should be able to then give to NHS England, and they can then look at this and try and normalize practice across the United Kingdom.